Good afternoon, Bustmob, and welcome to our interview with Dr. Fredman. Dr. Fredman is our Amelia Aesthetic St. Louis surgeon, and he is also in the Bustmob Ask a Surgeon group. So if you want to ask him more questions after this, make sure you check him out in the Ask a Surgeon subgroup for Bustmob on Facebook. But I am going to let Dr. Fredman in, and we are going to ask, or I am going to ask him a bunch of questions that you guys asked me to ask him. So here we go. Dr. Fredman. I've been looking forward to this all day. Hello.
Hey, how's it going?
Good. It's been a while.
It has been. How have you been?
I've been good, and you've been busy.
We've been busy. Yeah. Yeah.
So I have a ton of questions that a bunch of ladies have. Yeah, they want me to ask you all of these things, and we might get some that come through the comments.
Sure.
But if you just want to launch right into it.
Yeah, let's go.
All right, let's go. So number one, is it okay to be out in the sun soon after a breast augmentation?
So in general, yeah, it's okay to be out in the sun, but you have to be careful. There's two things to be careful about. One is you don't want to get a bad sunburn right after having surgery. With the changes that are going on with swelling and everything, having a sunburn on top of that would be a lot for your tissues to handle. So no sunburn. The other thing is you have to keep your scars protected from the sun. Now, in the immediate period after surgery, they probably will be anyways, because they probably have some sort of tape or bandage or something over it. But even in the whole first year after surgery, protecting the scar from the sun is helpful. Young scars that get exposed to a lot of SPF can permanently be more noticeable than other scars.
Oh, so no SPF on the incisions?
So, no, sorry. So young scars, young scars that are exposed to UV,
okay.
You need SPF, yeah. So young scars that are exposed to UV can be more noticeable. SPF is really important, especially in the first year as scars are healing.
Would you recommend people getting like extra tape and then just applying it over their scars up to the first year if they're like beach bunnies?
I think that's a great way to do it. As long as it's, as long as it's some thick amount of tape so that it's actually blocking UV, then that's totally fine. So either that or just a high SPF.
Got it. Here's one I had no idea what it was, and I had to Google it. I have ITP. I was like, I don't know what that means. Does that prevent me from surgery completely?
Okay, so ITP stands for immune thrombocytopenia, a long word. So, but it falls in the category of something that is not so uncommon, which is a problem with either bleeding, like a bleeding disorder, or a problem with blood clots. ITP specifically is a problem with platelets, which is one of the cells in your bloodstream that helps your blood clot. Because you actually, the term blood clots kind of gets a bad rap, but you need your blood to clot so that somebody stops bleeding. So It's a good thing, and you need platelets. So there's some disorders that cause platelet levels to be low, and ITP is one of them. But regardless of whether it's ITP or any other bleeding disorder or blood clot disorder, the question of, is that person a good candidate for plastic surgery? Is it safe to have plastic surgery is really important. And in those cases, the best person to be involved in planning for surgery is a person that specializes in that, which is a hematologist. So anytime I have somebody come in for a consult and they have a bleeding disorder, we get the whole story, but then we do have a hematologist that we work closely with, and they help figure out how they can get through surgery safely. And usually there is a way, whether it is just checking labs before, whether it is giving them an actual medication before. And there may be settings where somebody may say the safest way to do it is actually in more of a hospital setting, depending on the problem. But there usually is a way to work through it, but it makes sense to get a blood expert involved in those cases.
ITP, it's a new one. It's a new one to me. I want to have cleavage after my breast augmentation, very common. Should I go with a moderate profile implant if my breast width diameter is 13.5/14? So explain all of that to me.
Okay. So breast width diameter is a measurement that is measuring the width of the base of somebody's breast. And the first thing to know about it is not an exact science, because what actually matters is the space where the implant is going. So that means it's under the skin, it's under the fat, sometimes it's under the muscle. So there's some other layers there, meaning if you just take a measuring tape and you measure from one spot on the chest to the other, that's not really the width. So there is a little bit of plus or minus there, and that's why it's not an exact science. And that's why if somebody were to go to 3 different plastic surgeons, they may get 3 different numbers, 13.5, 14. So it's not an exact science. But what's really important is that you choose an implant that is consistent with the width that the person has. Now, if the person has a really narrow chest, then you need a narrower implant. If the person has a really wide chest, then you need a wider implant. It's important, especially if somebody wants cleavage, to take advantage of the width that a person has on their chest. Mm-hmm. You can go up and down a little bit with base width, similar to it not being an exact science. You don't have to put an implant in that perfectly matches the base width. But the main thing I would say to the person that wants to get as much cleavage as possible is make sure they are choosing an implant that is wide enough for them. So an implant that is going to be around that width. Does it have to be exact? No, but around that width, because if you're narrower, you're just not taking advantage of all of the width that the person has.
Got it. That's a very common question. I'm sure you hear that all the time.
Base width. Base width is confusing. But it's also really important, and it's also part of the reason why some people will say, "Well, I saw this picture of somebody, and they have a 350 cc implant, but on me, a 350 cc implant looks totally different," and that's because it's all about the width. Because in somebody that has a wider chest, an implant is distributed across a wider area. So they may need a larger implant to get the same look of somebody with a narrower chest with a smaller implant.
Totally makes sense. And I think that's where Goal Finder is really helpful too. Getting to see like different implants on like your similar body type and getting an idea of like, okay, that's a moderate or that's a high profile. My similar body style, different looks completely. So I think that's very helpful.
For sure. Yeah, absolutely.
How do I avoid capsular contracture?
That is one of the most important questions in breast implant surgery to ever exist. And there's been so much research into capsular contracture because it's a problem. Obviously, nobody wants capsular contracture. So if you can avoid it, that's the best thing to do. So there are certain things that we have found consistently decrease the chance of capsular contracture. And it's important that before surgery, somebody talks to their plastic surgeon about those choices. What choices can you make to lower your risk? What can be done before surgery? What can be done during surgery? One of the really important choices that can be made before surgery is whether you put the implant on top of the muscle or under the muscle. There's good research that shows that if your implant is under the muscle, you have a lower chance of capsular contracture than if you're over the muscle. There are some other things as far as types of implant, whether textured or not, that can also play a role, and those are important conversations to have. And then there's a lot of things that I do during surgery to lower the chance. There's like 14 steps during surgery that you take just to lower the risk of capsular contracture. And that's an important thing to have your conversation with your plastic surgeon about, asking, what do you do during surgery to lower the chance of capsular contracture? Because those things make a big difference. Unfortunately, there really isn't anything that has been shown after surgery to make much of a difference. You hear things that people say here and there that they think may help, but there's nothing that really has been shown to make a big difference after surgery.
What's something in the operating room that you do that helps to prevent capsular contracture to the best of your ability?
Yeah, so we think that capsular contracture has something to do with bacteria that somehow gets around the implant, either at the time of surgery or through the person's body. So anything that reduces bacteria, we think helps with capsular contracture. And that's why antibiotics are important, at least right before surgery. Washing the pocket out with some sort of solution that kills bacteria, not touching the implant. So many plastic surgeons use something called a no-touch technique, where you actually put the implant in with something called a Keller funnel, where you squeeze it in without even touching it. So that helps. We change our gloves. So a lot of things aimed at preventing the chance that there's even one single bacteria from getting around the implant.
That's cool. We have a lot of capsular contracture questions.
Yeah, it's a really important and interesting topic, and can be a problem, unfortunately, when, if somebody gets it. But again, as long as you do all these things, the chance is pretty low.
Would you say that the more breast surgeries that you have, the more likely or the more increased risk that you have of developing capsular contracture?
Yes, in that every time that the implant is interacted with, and that every time the implant sees the outside world, there's a chance something, is happening to it. There's some change. So technically, yes, every time there's an exchange or any surgery where the implant is involved, there's a chance of capsular contracture, but it doesn't mean that it's a high chance. And oftentimes, the benefit of that procedure is worth the potential increased risk of capsular contracture.
Someone just asked, what about taking Singulair post-op for capsular contracture?
Yeah, so Singulair is a really interesting medication. It's an allergy medication. So a lot of people are like, hey, I take Singulair. I think I used to take it when I was younger. It actually has been shown to help prevent worsening of capsular contracture in people that have capsular contracture. People have inferred from that, well, if it helps capsular contracture from getting worse, maybe if you take it, you can prevent capsular contracture. And it's a really smart thought, and it may be true, but there isn't a lot of research behind it yet. It's a pretty safe medication to take. So depending on the situation, especially if somebody's had capsular contracture before, it's not unreasonable to do that. And that's something I talk to my patients about. But there isn't enough evidence to show that it makes a difference to put everybody on it when they're getting implants.
Yeah. Like with my first two, I didn't take it at all. But with my third, maybe because I've had three, I was prescribed it, I think, for 45 days after my surgery, just as a preventative.
Yeah.
But it gave me a headache, and I wasn't a huge fan of it. But everybody responds differently to medication.
For sure.
Here's another capsular contracture one. Is capsular contracture something that develops slowly or quickly, and does it vary from person to person?
So that's a really good question. So yes, it does vary from person to person. Everybody has their own specific story with how it developed, both when it developed after surgery and its onset. However, the typical pattern that you see is not a quick thing, not like 1 week suddenly I woke up and it was very different, but a gradual worsening of it over time. And it's usually not right after surgery. It's usually in the years after surgery. So that in general would be the most common, but I certainly have seen patients that developed it early on and it was quick. And then there's people that develop it 20 years after getting implants, and it's kind of a slow development.
Let me see. There's another capsular contracture. Well, there is. If someone has it, is there a way to prevent it from getting worse? And then I went into a tummy tuck question. So, is there a way to prevent it from getting worse?
Yeah. So if somebody has it in its early stages, that's a really good time to start Singulair, to talk to your plastic surgeon about Singulair, because there is evidence that it can prevent it from getting worse. There isn't much else out there besides that has been proven to make a big difference.
But Singulair won't reverse it, right? It just halts it or
Correct.
slows it down.
Yeah, the research has shown that it halts it from progressing, correct, okay. But not necessarily that it treats it and makes it go away.
So is there a degree in which, like, how severe your capsular contracture needs to be before having surgery? Like, if it's just a little bit, do some people just live with it, or do you recommend them having it taken out?
Yeah, so it really depends on the specific person and their goals and how much it bothers them. I mean, if it is a small amount to the point where it's something that you see, it doesn't cause any pain or anything like that, it's reasonable to say, let's not do anything for now. Maybe it's not going to get worse, if the person is okay with that. If it is more noticeable or bothers a person, then it's worthwhile to do the surgery. And an important conversation to have is the surgery is not insignificant. Any surgery has trade-offs and risks, and the capsular contracture surgery is a little bit more involved. You have to take out the scar around the implant. There's some risks there. So you don't necessarily want to just do it unless it's consistent with the person's goals and it's a worthwhile trade-off. So it's a really important conversation to have, and is definitely very specific to each case.
When you're taking out the capsular contracture part of it, do you remove the implant and put a new one in, or do you keep the same implant?
Yeah, so you want to put in a new implant if the person has capsular contracture, with the thought being that if it had something to do with bacteria or some process, you want a new implant kind of for a fresh start after that.
Got it. I think that's all of our capsular contracture ones. Someone asked a question that I think a lot of people do ask. Kason said, I think I may have a spitting stitch. How should I treat it? Oh, I hear this question a lot in Bustmob.
Yeah, so what is a spitting stitch? Okay, so most people have dissolvable stitches put in under the skin. And the way your body dissolves it is it kind of disintegrates the stitch material and your body absorbs that material. Sometimes people, instead of your body absorbing it, your body will kind of push it out to the outside world. That's what people call this like spitting stitch. And sometimes people will notice some fluid around it. It might look like it's a little infected. It could get infected, but it isn't necessarily a real infection. But that's what a spitting stitch is. Now, sometimes by the time they've worked their way out, they're basically ready to fall off. And, you know, sometimes the person themselves just kind of pull it and it comes right off, or their plastic surgeon will just pull it and it comes right off. What I always tell my patient is if you notice it, first of all, it's not an emergency. But when you're able to come in, I'd be more than happy to just, you know, trim it and that's it. But also most likely if it's not infected or anything like that, it will just kind of fall off on its own because it's a dissolvable stitch. So there's some people that tend to kind of spit all of their stitches, or many of them. It can be a little bit more of an issue, but most often it's just kind of one here and there, and either it falls off on its own or we just trim it in the office.
So I saw another question come in on here where it was talking about mesh. So what is the instance when you would use mesh during a breast augmentation?
Yeah, so plastic surgeons differ on this. You will hear some plastic surgeons that always use mesh with all of their breast augmentations. The general idea is that it's important after, whether it's implants or a lift, that your tissues support the implant, right? You don't want to bottom out. You want to have implant position problems. And so it's important that the implant is supported. And most often, the person's own tissues should be enough to support that implant. Breast tissue is very strong. You know, skin is pretty strong, even though it can stretch. So the person's own tissues should be able to support everything. Now, if somebody's own tissues can't support everything, then you need to rely on something else, not from your body, to support the implant, and that is what mesh is. So in my practice, I rely on mesh when I find that somebody's tissues are not going to support their own implant. So maybe as somebody that's lost a significant amount of weight and have very little tissue to even support the implant, that person may be good for mesh. And more commonly in a revision situation where the person has already sort of shown that their own tissues can't support the implant and they've lost all support, then you got to bring in sort of backup to support the implant. I don't put in mesh in breast augmentations unless there's some other reason to, because I think the person's own tissues should be able to support it, and then it's just one less cost, less risk, things like that.
I forgot about being more cost.
Mesh is expensive.
Is the recovery different when you get mesh? Like, is it a little bit different? Like, is it firm at first, or is it a little bit more painful? Like, what am I looking at if I got mesh?
Yeah, so I don't necessarily think it's more painful. I mean, I think it would be similar to any what we call kind of pocket work, like when things need to be done to the pocket where the implant is. There can be some pain there just from tightening things. It generally is not nearly as, as much as the first time around because the pocket's already there. So I don't think mesh is much different in that regard. But one thing that can happen is it can take longer for things to settle and kind of stretch out and get to a final appearance when there's mesh in there, just because the point of the mesh is to be a really strong support and you want it to be strong. So it can just take longer for things to kind of settle. So it does sometimes require a little more patience to get to the final result.
Got it. Well, those weren't any of these questions. Those were just the ones that popped up. All right. So now we're going to move into tummy tuck land.
Right.
So let's see. I put brainless. Do you do drainless tummy tucks at a patient's request?
So I don't do brainless, but I do drainless. Yeah, so I do drainless tummy tucks, and in Amelia, we do drainless tummy tucks routinely. It's important to understand the idea of a drainless tummy tuck and when would you use a drain. So the idea is that after a tummy tuck or during a tummy tuck, the skin is lifted off and pulled down to make everything tight. And when you do that, there's space under the skin where fluid can build up. And if fluid builds up, that can be a problem. It can get infected. It can make things not heal as well. So you want to close off that space. So one way to do that is by putting a drain in that pulls off all the fluid. But then you got to deal with the drain and kind of the inconveniences of that. So the drainless technique is you use dissolvable stitches under the skin, and it closes off any space. So there's no room for fluid to collect. So you don't need a drain. So that's the idea of a drainless technique. So that's our routine technique here. The only situations where I'll still have a conversation with somebody about a drain is people that are in the higher weight categories for when we do a tummy tuck. So approaching BMIs of 35, those people just tend to produce more tissue fluid. And then it's an important conversation to have with your plastic surgeon, like, okay, you're doing the drainless technique, but would there be any benefit in leaving a drain in still in order to prevent the risk of fluid from building up? So it's still important to talk about, even if you do the drainless technique, but it's very uncommon that I end up leaving a drain in.
Woo. Can you have a nice tummy tuck result if you have multiple scars on your abdomen?
Oh, that's such a good question. So scars on the abdomen for a surgeon are like a roadmap into the person's history. Like a surgeon can look at someone's abdomen and see scars and say, okay, you had your gallbladder removed and you had your fortunately, most scars on somebody's abdomen are kind of below their belly button, whether it's a C-section or an up and down scar or kind of laparoscopic ports or from an appendix. And usually that is skin that's getting removed with a tummy tuck. So that's great. Not always, but usually. Sometimes if someone had laparoscopic surgery where they're going with, with cameras and things, there may be a little scar here and there that gets left behind. There's one scar that fortunately is uncommon nowadays that can be a problem in a tummy tuck, and that is the scar that they used to use when they removed people's gallbladders. And that is a big scar that goes across the right side of the person's upper abdomen. And that's how they used to do gallbladder surgery. So it's very uncommon nowadays that somebody has that scar. But the problem with that scar is that a scar doesn't just go through the top layer of skin. Scar goes through the skin and the fat and the blood vessels and everything else going deeper. So when somebody has that scar, they've cut off blood supply to the skin that's going to be on the abdomen, and it can cause a lot of problems with healing and increase the chance of some pretty bad complications with healing. So in general, when someone has that scar, I usually won't even do a tummy tuck. That's one of the ones. So that's one of the one scars that when I see can be a problem. But generally, everything else is either removed or doesn't stand in the way of anything.
Kind of like a C-section scar. Those can be removed too, right?
Yeah, and the C-section scars are usually removed because the lower incision goes below that C-section scar.
Cool. What else we got? What are some telltale signs? That's a hard one to say. Telltale signs of when to call the doctor. So like if your fever is a certain temperature, like a certain, I don't know, like a length of time of fever, like what are the reasons that someone would be like, I need to call my doc now?
Yeah. So in general, what I tell my patients is if you're worried about something, just call us. Like, I don't know that people know how much we want to know if there's something they're worried about. And well, so how do you know what you should worry about? One of the best indicators would be some sort of sudden change, something that wasn't there before, it wasn't red before, and now it's red. Okay, we want to know about that. Or I wasn't having fevers before, and now I'm having fevers. So some sort of change, that's a good reason to let us know. Fevers specifically can be a little bit tricky because it actually is not uncommon for someone to have a fever within the first 1 to 2 days after surgery, and it does not at all mean that the person has an infection. It's actually just your body's response to anesthesia and just being asleep for a little bit during surgery. So that's usually an easy one that I can reassure someone, like, you don't have an infection, you're fine. But in general, if there's something that changes, especially if it's on one side and not both, that's a good reason to just reach out. And it never is the wrong thing to do to just ask. If most of the time these things are normal and just part of a normal recovery, and then we tell you.
Yeah. What would be, can you hear that? Oh, it's very loud out there. What would be your approach for revisions in this scenario? So this is like a story time.
Okay, yeah.
All right, so Implants dropped too low due to skin stretching back out. Had 3 kids, lost a lot of weight. Technically not bottoming out, but definitely looks that way. So I guess her skin has stretched a lot. And she had 550cc silicone under the muscle with a lollipop lift. So what would be the approach for a revision?
Yeah, so it of course is going to depend on her specific anatomy and goals and things like that. But it sounds like in general from that description, what she'd be looking at would be an implant exchange, and the size and things like that are going to depend on her goals and whether she wants to stay a similar size. And Goal Finder is a great way to do that. And probably a lift also. It sounds like she needs another lift with at least a lollipop scar, maybe also a scar in the fold, because if the skin is really stretched out a lot, that may be needed. And that may be a scenario where I would say, depending on how things look, maybe mesh would be warranted if it really looks like her tissues have thinned out and there isn't any support there.
3 kids, that'll thin some stuff out.
Yeah.
All right, and are hard knots around the lift incision line normal? And I think she said she was like 2 weeks post-op, but she feels like some knots along her lift incisions.
Yeah, so that is really common. There's a few things it could be. One is it could be suture that's under there, dissolvable suture that's going to dissolve, and those will go away. It could also just be scar. Things like that almost always go away. It's important to ask your plastic surgeon, when are they okay with you massaging it? Generally, scars, things like that, get better with massage. So if one of my patients noticed something like that, I would tell them to start massaging it gently, and it would soften up over time. It's important for people to know that scars on the outside are their thickest at about 3 months, 3 to 6 months. And by a year, they've gotten visibly less noticeable and thinner. It's the same thing on the inside. So scars on the inside can be thick in that 3 to 6 month period, and by a year they soften up.
That makes sense. I never even thought of it like that. And I think this is our last question. What should you do if you still have tenderness around your incisions during massaging after a full anchor lift and implant exchange? She's 5 weeks post-op.
Yeah, I would say the first thing to do is not to worry. That sounds totally normal. Like, it's very normal for incisions and scars to be tender. The nerves are healing, nerves are regenerating. And it actually is a good thing to massage when there's some tenderness. Nerves that are healing like that feedback. It helps them kind of calm down. It gives them something to do. So if my patients say, like, my incision's tender, I tell them just keep massaging it, even if it is a little uncomfortable. Now, if there's specific areas that cause a lot of what we call nerve pain, like really sharp shooting pains, like things like that, you can talk to your surgeon about a nerve pain medication, like something what's called gabapentin. But in general, that sounds like a normal thing that'll get better.
I see we got a question here. Going on a cruise, 4 weeks post-op.
She's on a cruise. That sounds nice.
Oh, you're on a cruise and you're watching our live. How do I know my incisions are fully healed? Or are you supposed to wait 6 weeks before jumping in the ocean? That's a good question.
Okay. So I take it she's not in Antarctica cruise.
No.
Hopefully not. So I tell my patients to wait 6 weeks before going in an ocean. You have to be really careful with an ocean. An ocean has a lot of gross things in it that you don't want getting into your incision. And I would be really careful before 6 weeks for both an ocean, a pool, a hot tub, things like that.
Well, I think if she's on a cruise, the hot tub is like a hot place to be.
Yeah, maybe just her feet.
What's your thought on hot tubs?
Yeah.
Do you think those are clean?
Yeah, no, they're not. She can put her feet in.
There you go. And last question, Steph said, I have slight lateral displacement and my plastic surgeon said it could be fully fixed with just a few stitches. What is the recovery like for that? Yeah,
so that type of pocket work, again, with stitches is not so uncommon and is a pretty straightforward procedure and usually a really easy recovery. Again, the pocket's already there. Usually those patients wake up and they're like, oh my God, this is nothing. Now, those stitches can sometimes cause some pain just where they are, because they have to be strong and they have to be kind of down to the chest wall to do what they're going to do. So there can be some pain there, but in my experience, it's not like the first time around.
That's good. All right. Well, it is 1 o'clock. We spent 30 minutes on here, and I know you got to get back to work. Yeah. And I want to thank you for taking time out of your day. I know you're busy, and a lot of women appreciate you answering their questions and being in the Ask a Surgeon Bustmob group.
Oh, my pleasure. I love doing this and happy to be here.
And I think we're going to do this again in a month.
Yeah, can't wait.
So I will get more questions, and we will be back.
Okay. I'll see you soon.
Thank you, Dr. Fredman.
You're welcome. Thank you.
Bye.
Bye.